Good morning, ladies and gentlemen, and welcome to today's session of the Healthcare World Series. Great to have you aboard. My name is Steve Gardner. I'm the Managing Director at Healthcare World. And this morning will be the third in our series of sessions talking about the Healthcare Transformation Programme in the Kingdom of Saudi Arabia. Those who've been involved in watching previous sessions will know that from a personal point of view, certainly I believe this to be probably the most exciting healthcare project or healthcare program of my lifetime. We've already talked about the formation of the clusters in Saudi and the way in which that's affected the moves towards creating an entirely new healthcare system. We've also talked about digital and data. And today it's the turn of infrastructure. We're going to be talking about infrastructure, capital projects and PPP in the kingdom. PPP will play a huge part in the development of the clusters, and particularly when it comes to their strategy around the renewal of their facilities and of the creation of new buildings. So I have with me today a really exciting panel, a panel with a depth of experience from all over the world. So in no particular order, we have from the National Centre for Privatisation and PPP, Sultan Lamir. We have Mansour Ahmed with us from Colliers, who's reliably informed, has now spent 22 years working in the property market in the region. Barry Francis Consultancy, a long-standing expert on public-private partnerships, both as a lawyer and more recently as head of healthcare infrastructure at Healthcare UK for the UK government. And last but by any means not least, Richard Cantley, head of healthcare from Mott MacDonald, and a long-time exponent of UK organisations working in healthcare infrastructure around the world. Welcome to you, gentlemen. Before we start, just to say that you have a red button on your screen if you're watching this on our website. Push the button and it'll give you the opportunity to type questions for the panel. Please do so throughout the morning session. We'll be with you until 11:30. So without further ado, let's get on to the questions. And Sultan, I'd like to start with you, sitting as you are in country. What does the healthcare transformation in Saudi look like in terms of the plans around, planning, refurbishment, infrastructure, capital projects, etc.? How big an element of this healthcare transformation are they, and how do you see all this working? Sultan, to you.
Yes. Thank you very much, Mr. Steve, for the introduction and allowing us to be a part of such an esteemed panel of speakers here. And to answer this question, we have to take a step back on how the envisioning of the health sector and the transformation that is happening in it, because we are talking about a part of some. And the fact is that throughout the presence of Saudi Arabia here and the engagement of the healthcare in Saudi Arabia, and as by law, since the delivery of the healthcare services is provided freely for the eligible patients in Saudi Arabia, it was mandated that the service delivery has to be given free of charge publicly throughout the Kingdom of Saudi Arabia. And Kingdom of Saudi Arabia is a big country. It is almost a continent, and it envisions more than 3 or 4 countries put together. And to deliver an equitable service throughout this country with the disparity in the population distribution, disease distribution, facilities availability is a challenge. So in the past, Saudi Arabia was advocating the spending on healthcare as one of the major spending streams in the national announced budget. The question is how this spending translates to service delivery. We found out that despite the fact that spending is significant, it is not reflected in an equitable manner. It is not. If we measure it by the outcomes, it is not in the best equation. And for that, the redesign and re-envisioning of the healthcare ecosystem in its entirety was a must. And one element of it, and significant element, is not to reduce spending, but to put spending and to get the best value out of it. And one key element of it to make sure that we have the infrastructure, hospitals, infrastructure, specialized services distributed by the need, not by the overall coverage. And for that, the needs studies have been ongoing. A lot of the opportunities have been collected, and amongst them, a big significant portion goes to the hospitals commissioning, whether as a green field or brown fields. And we are talking about significant number to start up or to start with. We are talking about more than 3,000 beds throughout Saudi Arabia that are announced in PPP projects, like the ongoing, actively working Prince King Faisal Hospital, Medical City in southern region, Prince Mohammed Medical City in the northern region, Sabiq Psychiatric Hospital, Al Ansar Hospital, Al Iman Housing, and many other projects. So it is a big component. It is aligned with the clusters that are envisioned, aligned with the transformation of the service delivery. It has to go hand in hand to enable the transformation, in the same time to provide the service for the end user of the service, which is the patient. I hope I answered the question.
No, a fantastic answer and really, really helpful. So, Sultan, if I could just delve a little bit more into this, where will the responsibility for infrastructure planning sit? Does it sit within, from the general perspective, we've seen the Royal Decree in the last few months creating formally the Health Holding Company. We have the Ministry, which now sits as regulator, the National Health Insurance Company, and of course, below the Health Holding Company, now the clusters responsible for ultimate delivery. So is there a national infrastructure program, and where does that sit? Or are we devolving the responsibility for the development of infrastructure programs to the individual clusters?
This is a great question that has to be taken with multiple elements, or from multiple angles. First of all, as you're all aware, PPP engagement is a long-term engagement, where the design of it has to focus not only to create a business deal, but also to create a beneficial, properly designed deal that gives the ultimate user, which is the patient, the best case scenario. In the meantime, providing a profitable case for the private entity, as well as delivering the outcome for the government entity. With that said, there are two parallel streams working here. The stream of transforming the healthcare ecosystem in its entirety. We are talking about the legal side of it, the financial side of it, the operational side of it. In the same time, we have an ongoing operation that has to be, in case we touch it to increase the efficiency and to add value to it. So with that in mind, as I'm telling our colleagues here, the issue with our transformation is, if we compare it, it isn't easy to tell them for a mechanic to work, because you bring the car, you switch it off, and you enable him to work. It is, to a certain extent, easy for a surgeon to work, because you sedate the patient and then you enable the surgeon to work. But in our case, we are asked to do an operation on a patient that is running on the field, and we are expected to push him and to increase his speed forward. And for that, it is very important to make sure that we are creating value by creating opportunities and projects that are easing the transformation for the ecosystem, enabling the healthcare authorities to focus more on building the capacities and adding value to the transformation and to the end state of the ACOs. At the same time, making sure that the transition of the legal frameworks and the structural frameworks is properly done on a project-by-project basis, and also in line with an overall governance to ensure the smooth operation and business continuity. And the fact is, to get that done, the first projects were created as an exemption of a government procurement. till the law have been designed, read, evaluated, and we have the PPP law, which was announced back in February 21. Upon the announcement of the privatization law in 21, still there are certain projects who have been approved prior to the law, after the law, etc. And for that, the implementing regulations which are approved back in September 21 are envisioned. So we are moving in the proper design to establish the best governance structures that enable the projects to work. But to state that there is going to be a specific entity that is going to deal with the project management or the tenure management or the structuring of it, it is still is a work in progress. However, there is our Center for Privatization, which works as the National Center for Privatization and PPP that governs the whole Kingdom of Saudi Arabia privatization projects that fit within its mandate, and is working in line with the overall arching regulations and in line with the Vision 2030 and the strategies of sectors, and amongst them is the health sector, of course.
So in many ways, at the moment, you're in a situation where you as a body, as the National Centre for Privatisation, are almost providing the glue between the kind of ministry, clusters, health holding company, and holding the structure, holding the kind of PPP and projects in your hands, so to speak.
Sure. By the regulation, every project is worked by a working team that reports to a supervisory committee, which is composed of the relevant ministries in the government. So there is a clear, transparent, well-controlled environment to establish it that has both the strength to work as well as the agility to move forward in case if there is any impediment down the road.
Really helpful. Richard, I think you wanted to come in at this point, didn't you?
Yeah, thank you, Steve. So it was just to really raise, how exciting this transformation program is in Saudi Arabia, but almost just stepping back a minute, as Saudi Arabia looks at this transformation and looking at what its healthcare system is going to look like in the future, so it's always good to just sit back and think about, the ultimate aim here is a focus on the health and well-being of the population of Saudi Arabia. And, before we start thinking about the healthcare system and, hospitals, etc., I think Saudi Arabia, given the transformation that's happening across the whole country, across, many different sectors, it's got a real opportunity to, be thinking about health and well-being for all and designing systems around that. Healthcare be one of those systems. So, it's first and foremost, there's more and more focus on prevention and stop people falling ill in the first instance. And, that's around about public health programs and that component, but also, given the amount of infrastructure delivery outside healthcare there's an opportunity to always be putting health at the forefront of everything that gets developed in Saudi Arabia. So, thinking about healthy cities, healthy buildings, etc., and really contributing to, keeping people healthy in the first instance. That then leads to, if you can have that front and center of the whole transformation of Saudi Arabia, that's about, in theory, reducing the demand for healthcare. But then you will need a futuristic healthcare system and infrastructure. And again, I think it's important now to be clear about what we mean by infrastructure. Often we talk about infrastructure and immediately start thinking about buildings or acute hospitals. And, I think now when we refer to healthcare infrastructure, we do need to think about, digital infrastructure and what can be done digitally in terms of monitoring and interventions, and preventing the need for people to have to go to buildings and hospitals. And then we will obviously need, hospitals. And it's about thinking about that network. Yes, you need acute hospitals, but strategically planning the right assets in the right place. So, I think there's a real opportunity given, and it's a really exciting Arabia is. They can really put the focus on health and well-being. They can put in place the health-led infrastructure, the public health programs, and then think about what that healthcare infrastructure is, both in terms of digital infrastructure and then a network of healthcare facilities ranging from local clinics, primary care centres, all the way through to acute hospitals. So, it's a really exciting opportunity for Saudi Arabia really to be the leading light here in terms of what that joined up holistic approach to maintaining the health of the population is.
Sultan, you wanted to come back on that?
Sure. Thank you, and thank you, Richard, for the input. And here is a point that I want to state to show that how prime the opportunity in Saudi Arabia is. Mr. Richard have spoken, and I do agree with him totally about the importance of the digital as it can be encompassed by the definition of infrastructure. And we are in full alignment with his point of view. And actually, even digital health is one big element that is going in parallel with the medical cities building and the setting the standards of the ultimate healthcare ecosystem that we are working toward. At the same time, it goes in line with multiple other projects. So all of the privatization projects within the health sector are structured and governed and in line with a unified strategy aiming toward one complete cohesive system. And for that, there are multiple elements and projects who might seem to the first look are a bit fragmented, but they are well organized and well harmonized to make sure that the ultimate result is unified and the goal, and actually the goal is one. So at the end of the day, they are putting all of the efforts back into one unified healthcare ecosystem that provides the best value for the patient with the best utilization of the money spent into that operation.
And I want to come in on that point myself, Sultan, because myself and Ritu Chopra, our operations director, were out in Dammam and then in Riyadh last week, and we saw this for ourselves. Spent a great deal of time with the senior leadership team at the Eastern Cluster out in Dammam. And what really impressed me, coming to Richard's point, you look at the Eastern Cluster, for example, where you've got, I think, 450 square kilometres. They're responsible for 22 hospitals and 120 clinics over, as you said in your opening point, a huge geographical area with a lot of hard to reach rural communities. But you look at the way in which people like SML Newman, as the head of digital health, are looking at the ways in which they can create triage at home. They can create virtual wards post-operatively. You can have this situation where you're joining up the healthcare at home element, the ability for people to understand when and where they need to actually engage with infrastructure, reducing the kind of pressure on the health system. The fact that that is all as joined up and well thought out as it is one of the really interesting and important elements of the transformation, I think. I think there are some challenges. There are some challenges around the need to actually create and refurbish and move forward with new infrastructure, particularly in terms of primary care. And the other issue, I think, which touches on what Richard was talking about a moment ago, is population health management. Now, we spent some time with Dr. Saad, who is the head of population health for the Eastern Cluster. And I think there's a recognition of what having good data, having good population health management in place can achieve for Saudi Arabia. But the issue at the moment is, how do you get the data that you need? If we can actually start to source good, reliable data, then that actually will start to input into how some of these infrastructure decisions are made. So in other words, if we know the disease profiles and we know that the locality of some of the people that are suffering with different conditions, we can use that information to fuel and understand what infrastructure we require and where. And I think that speaks nicely to Richard's point. I want to move on a little bit. I'm interested and curious to understand the market as it stands at the moment, what opportunities we are seeing in Saudi Arabia in infrastructure terms. And I think from that perspective, Mansour, you're the expert there. What kind of projects are you seeing coming through Saudi? What kind of stuff is in the pipeline in terms of Saudi infrastructure?
So yeah, I think Mr. Sultan and Richard, they have basically highlighted some of the very important thing, and I would also add a few points. But just looking at the market, I think at this moment, the last data which we have is 2020, we have like 76,800 beds in Saudi altogether, out of which 75% are in Ministry of Health and other government entities like National Guards and others. So 75% of the beds are at this moment in public sector or semi-public sector, and only 25% are in the private sector. And so that's one thing. Second thing is, if looking at the population growth, which was 4.3% on average CAGR for last 10 years, if you look at that, you will need additional around 20,000 more beds by 2030. So there is two things are there. One is to basically build 20,000 more beds, whether in the private sector or the public sector. And the second thing is that having this 76,000, 77,000 beds, they are of, some are 10-year-old hospital, 20 years old and 30-year-old. So there is a need to be a, sort of a renovation, upgrade, and other. So you have looking for two set of basically investment. We did some, we were supposed to issue a paper by today, but there was some delays in that, but we did an analysis and we'll be issuing a paper on, capital financing of healthcare sector in Saudi in a week or 10 days time maximum. But based on that analysis, which we did, so to build those additional 20,000 beds, based on the average cost of construction, and we're not looking at just the real estate cost of construction, the medical equipment, the fit out, and even considering the most of the hospitals, they take three years to do operating break even. So even looking at the first 3-year losses, another, we need around 35 to 40 billion dollars new investment just to build those additional beds which are required based on the more additional population, and then revamp the existing one. So it's a big take, whether it came from the private sector or from the public sector. So there is so one thing which we have done is we done some analysis, another that which the privatization is happening. We are involved in number of REITs projects and sales and lease back and whatnot, that if we look at the current value of just the real estate, I'm not talking about the operational, the business side of it, the 76,000 bed roughly, and a detail will be there in our paper, 76,000 bed roughly, the value is around 60 billion US dollars. And so, and you need around 40 billion to build the new beds, 20,000 beds another. So you're still left with around 20 billion or so, which can be used to upgrade, renovate another existing hospitals another, which will be, so there won't be, if we go that route, there will not be too much, burden on the private sector, on the private or the public sector, because you're sitting on a valuable asset which are locked and it's not generating any income, which can be unlocked, which can be unlocked and used to renovate, upgrade, and build new hospitals and other. I think one more thing which I wanted to add is here is which is very important, that normally when we talk about upgrading the infrastructure and building new hospital, normally people just think about having hospital beds and also having like digital health and other. I think one most important thing which we have seen in Saudi privatization program is that, as you were mentioning, Steve, that they have looked at disease profile, although this is one of the challenge which we have it, and we also get that getting data is a very challenging, but they have looked at it, and the focus is not to just build more and more bed. The focus is that segregate what is required. For example, there is an emphasis on long-term care. But at this moment, and Mr. Sultan and other people can correct me if I'm wrong, around 20 to 30% of long-term patient occupy tertiary care hospital beds and other where there's no need for them to be there because they are basically blocking those beds. Other thing is also which we have seen, which is a very good thing, is home care. That you gradually move a patient from a general hospital to a long-term rehab hospital and to the home care to reduce the burden. One more thing which we want to emphasize is that that we need to also look how the advancement in technology and everything will going to impact the demand in the future. So if you look at NHS, I think 20 years back, they were doing only 20% of their surgeries, surgeries in daycare setup. Now, the last year they were just before COVID, they were doing around 76%. And by 2025, they will be doing around 84% of their surgery in a daycare setup. So I think when we are planning and what we have seen is that there is still less emphasis on that. That I think in Saudi only now 32% of the surgeries are done at this moment in daycare setup. In Dubai, it is almost reaching 50%. So I think one more thing is that when we are doing the planning, we need to little bit be more careful about that how the technologies are changing and everything, and how improving technology has reduced the average length of stay, which used to be like 10 days plus in 1970s, another, and now gone to 3 days another. That we should see that what kind of disease can be treated in a daycare setup so that it will require less less investment and less. I think these are the things which I want to highlight is that there is so in short, there is a lot of investment is required, but we are sitting in a gold mine of existing assets which can be unlocked. Plus, there is already emphasis on LTC and home care and other. And recently, there is more demand is a focus on maternity and child care also, because that is one of the main disease also. And also the daycare surgeries. And we do need to look at some other things, like we were doing some work with our UK office, and we looked at that now some of the chemotherapy and other, you don't need to go to hospital. They are offering on a retail setup in a mall. Urology dialysis are happening in a retail setup in a mall. You don't need to go to hospital. So we also need to see what services can be take out from the hospital and can be done outside the hospital, where first of all the patient need less time to travel. They are more in a relaxed manner getting those things instead of having this mindset that I have to go to hospital, and that's also required less investment.
Thanks, Mansoor. Thanks, Mansoor. I mean, there are a couple of points that you've raised there that I want to pick up on. Most specifically, when we talk about, it's worth mentioning, because you talked about the difference between private and public sector. When we talk about the healthcare transformation in Saudi Arabia, I think it's important to mention that we are talking primarily about the public health system. As Sultan said in his opening piece, there is a mandate in Saudi Arabia that healthcare will be free at the point of delivery to all citizens. And I think that's one of the wonderful things about this, actually. I've talked about this in the past, about the fact that it almost feels to me as a resident of the UK like the Saudis are inventing their own version of the NHS, but doing so in a digitally enabled integrated care setting with a budget to do it properly. Although ultimately the establishment of the Health Insurance Corporation is all about creating a tiered national insurance model, which ultimately will be sold off to the private sector. So in terms of our the future of payer relationships in Saudi. At the moment, the payer strategy is, or the payer structure is, Ministry of Finance to Health Holding Company, and then as they form to clusters, it will eventually be Ministry of Finance to commercial insurers to clusters. That's the way in which it will work. You also brought up the point, Mansour, about investment, though, because at the end of the day, this isn't just about using Ministry of Finance money in order to finance the revitalisation of the healthcare system, particularly from a public health system perspective. There is a big emphasis on PPP and on bringing in investors to help with that design, build, finance, operate PPP structure. And I want to come to Barry on that in a moment. The other thing I wanted to cover, though, was that third point that you raised, which is the one about essentially integrated care. Integrated care is very, very much front and centre in terms of what the Saudis are trying to achieve. So you talk about the Eastern Cluster example that we saw last week, the idea of kind of home care, digital health, remote digital triage, to primary care, to acute care, and then back to home for virtual wards and monitoring, with all the other bits and pieces taken out. So again, you can start to do some of the daycare things that you were talking about. You can start to design facilities around the idea that it's day cases rather than overnight stays. But a lot of that will require particularly refurbishment of existing facilities. And I think that's a kind of big opportunity. And a lot of that will come not just in large-scale PPP programs, but also in small-scale ones. And on that note, I want to go to, well, in fact, I'll go to Sultan first, because Sultan's got his hand up. And Barry, thank you for being patient. I'll come to you in a moment. Sultan, do you want to come in on that point?
Thank you. And thank you, Barry, for your patience. I mean, we want to have the opportunity to learn from your vast experience. And by showing our what we have did and how we did it, and then we can build on that. You mentioned quite clear, Mr. Steve, that and also Mr. Mansour, about the investment in the infrastructure and the healthcare. And you will state, Mr. Steve, that you have seen in the Eastern Province the how the design is doing. And adding to that is the issue of the data and how we cannot let such impediment to stop the further movement of it is the fact in Eastern Province, and I'm not stating something that is not already publicly available, is that because of the high incidence of the sickle cell disease in the Eastern Province, it was selected as the pilot project to properly manage the complete clinical pathway from the prevention of the disease till the first upon the detection, what is needed to be done for the sickle disease patient on a primary care level, going to the secondary, tertiary, and if God forbid, whatever hospice requirements for the sickle cell disease, not for the sickle disease in particular, but to provide a good model that can be replicated in all of the other chronic diseases, all of the, for example, oncology cases, etc. So this adds value to the fact that the system works in an integrated fashion that might not be seen integrated in the first place. Thank you very much.
I think that's a really good example, Sultan, and thank you for that. And it has impressed me greatly how much thinking has gone into the creation of this program in terms of, not just thinking in the old way about hospital beds, thinking about more than just hospital beds, thinking about the different elements of the system and how we bring them together. Barry, I want to come to you and like I say, thanks for your patience. PPP is clearly going to play a massive role in the revitalisation of particularly the healthcare facilities in Saudi Arabia. And in your recent role with Healthcare UK, you'll have seen a lot of infrastructure organisations, investors organisations looking for opportunities around the world. I wonder, could you give us an insight into how much, what is the level of international enthusiasm towards Saudi Arabia? And from your perspective, where do you feel they're up to in terms of their readiness and their ability to deliver large-scale and small-scale PPP programs?
Well, that's a big question.
You can give a big answer, Barry. That's
okay. I'll talk, and Steve, you have experience in stopping me from talking for too long, so just stop me when I talk for too long. I think there is clearly a great deal of interest internationally across the various actors in healthcare and healthcare finance for the program in Saudi Arabia. there is money available, there is a plan, it all fits together, it's being thought through, there is a law which has been developed and is being developed. So all of that fits quite neatly, and or not neatly is the wrong word, but that all those factors are attractive to the international community, whether you're talking about finance or whether you're talking about delivery, building, operations, and so forth. I think it might be worthwhile just taking a step back and in the context of PPP and healthcare, just looking at the key factors that we've learnt about from different types of projects in the UK and in many countries where experiences are different. And I suppose the first, that experiences are different, an absolutely key point, that if one looks at the new Saudi PPP law and the regulations that are emerging from it, clearly that law is designed to be flexible. It covers a whole range of PPPs because to fall within the legislation, you just have to have 2 of 5 or 6, I've forgotten the number, of key points about delivery. So I think the flexibility of the law is again attractive. But flexibility can itself create some issues. You've got flexibility, you've got a central organization to oversee the development of the law and the development of the projects, and that ticks many boxes. I think the issues then become on the other side, and just picking up on points which Richard and Mansour both made, and all of which I agree with. The need for flexibility in terms of your planning and all the matters that will have to be dealt with over the length of the project, or if you look at it in financial terms, over the tenor of the loans. And I think there you do come across something which will have to be managed very skillfully, and where in different parts of the world managed better or less. So first point is in deciding how these projects are going to develop. Key point is understanding what is happening in Saudi Arabia, what is wanted in Saudi Arabia, and what is happening in the markets. So sometimes people say to me, so what did you do in Britain? Because I did a lot of the first and subsequent PPP hospital projects in the UK. And that's relevant, but the structures and the risk allocations were fixed very much at what the markets in the late 1980s through the 1990s, early 2000s. So what was the appetite for long-term debt? What was the appetite for political risk in the United Kingdom? What was the insurance market internationally at the time? So how will risks be managed and who will take those risks will vary from country to country and from time to time. And that then brings me on to, I think, the other tension that you have in doing PPP in healthcare. And that is the need for flexibility and at the same time, the need for certainty. Wherever the money is coming from, we've got, we're talking, and if we're talking buildings, and it's much more than buildings. And I think that, and the fact that the buildings have to be seen and planned in the context of the wider issues which both Richard and Mansour have talked about. But whether you're publicly or privately financing infrastructure, you're talking about buildings and things which you want to last for what, 20 years, 30 years longer. In the UK, theoretically 60 years, which is and you're talking about loans which will probably be around now, probably about 15 years, something like that, maybe less, maybe longer, assuming we're talking about finance-led PPPs with heavy capital investment at the beginning. And the only certainty, and you need certainty for those sorts of projects, and the only certainty is uncertainty. And that, how you manage the uncertainty and how you're planning to manage the uncertainty seems to me to be absolutely key, both to the reassuring the investors of whatever type, financial investors or investors of skills and so forth. And also in making sure you get value for money is how do you manage change? Because the only thing that we know when we build a hospital is that whatever we're building now, we will not want it to be like that by the time the loans run out, or by the time the loans have been repaid. So how do you manage that change, both in a planned way and to cope with sudden unexpected emergencies? And COVID is I suppose, the easy example. How do you deal with surge demand? And Richard had a huge amount of experience in that in the UK over the past few years. So you need flexibility in your buildings and flexibility in your service delivery. But at the same time, you've got effectively banks sitting there saying, I just want my certainty of revenue stream, because I have lent on the assumption of I lend the money, you get the building, and then then I bank get my money every month. The check turns up. Well, the check, but talking old-fashioned ways. So the management of those variations, which actually I've done a number of variations of major hospital projects, and they are really difficult to do. And how do you then plan to bring people together and ensure that you can, both in a structured way, when you see changes in both the diseases and illnesses you have to manage, and the clinical responses, the development in medicine that you see to respond to whatever you do need to respond to, and also surge demand. Suddenly it's all different. You have to manage your hospital in a different way and so forth. And that brings in the need to design both into the buildings and into the systems and into the financial contractual packages, the ability to manage change as efficiently as possible, and in a way in which the public purse pays up, because ultimately, once a nation has decided that as a matter of policy, it will manage healthcare and require healthcare to be free at point of delivery for its citizens, ultimately the risk will always lie with the state. That's a fundamental point. It's how you manage the risks up until that point, and how do you make sure that the state pays where appropriate, for otherwise either you will not get the financial investment or the financial investment will be overpriced. How do you manage that and at the same time make sure it doesn't overpay? And I think those are the key points which, as these projects emerge and are managed, that need to be borne in mind, both to reassure the investors and to reassure effectively the people, the state, that the value for money is being and will be obtained. And I think and then there's a whole series of factors around there about compensation packages but there's one other point I would just mention before, Steve, you feel constrained to stop me. And that is the involvement of different public agencies in the development and management of the projects. So we have planned in Saudi central oversight of the development of PPPs. And in the UK, when we were going through these programs, that was effectively a function of the Treasury, with various specialist departments in the various ministries, including the Department of Health, it was then called. And that makes perfect sense. And you need to have central control, because you do not want to have lots of different risk profiles for contracts being debated endlessly, different solutions on the margins being achieved after another 6 months of negotiation, where actually you've ended up more or less in the risk profile position that you would have ended up on day 7. So that's just a waste of time. On the other hand, 2.3, 1, health is different from roads. And it might be an obvious statement, but in terms of your PPP, the most obvious differences are that in roads, most of the risk is in the construction phase and some of the risk is in the operational phase. If you look at healthcare, there is risk in the construction phase, but so long as, and these are big so long as there is clarity as to what is wanted to be built, so you don't keep changing your mind while you're building it. So long as there's clarity of what is wanted to build, and so long as competent main contractors are being hired, and there's loads of competent main contractors around the world. The risks are relatively low compared to the operational phase, which is plagued with those risks that I've just mentioned over the tenor of the loan and over the expected lifespan of the building. You know you will need to do change, and all sorts of things will happen. And you've got issues about are there enough staff? Are there enough skilled staff? What happens with change? So the need to recognize the risks in the operational phase, which brings me into my final point. Central control and oversight, absolutely vital. But the next point, I think, is ensuring that those who will be responsible for managing the contract as it in the operational phase are involved in the development of the project itself. And I know at least one country where that wasn't done, and I think life would have been better and easier if it had been. And that then ties into the need to ensure that the contract is well managed on both the private and the public sector sides, staffed with people who actually know what the contract says. And I think it would be fair to say that in many countries, including perhaps one I'm sitting in at the moment, that was not necessarily always done. To make sure that the contract is properly managed, and this really then comes back to the need to change, to manage change and anticipate change and do that effectively. I've taken too much time, Steve, so I'll stop there.
I mean, the next time I say, Barry, you can give a big answer, I might want to think twice about that.
Yeah. It's all definition. It's all definition, Steve.
To be fair, Barry, that was a long answer, but it was also a fascinating and a hugely insightful answer. And I think it raised some really, really interesting questions. And Richard, I know you want to come in on this, but before you do, one point that I particularly picked up on here, and you and I have talked about this many times in the past, the whole idea that, the one constant in a healthcare setting and thereby a healthcare PPP is going to be change. And actually, what's interesting, I think, about the Saudi program, and Sultan, I just want to get your thoughts on this. But change is baked in. Change is baked in as part of the program. Because I spoke earlier on about the structure and the division of the Ministry of Health into regulator, health insurance company, health holding company, clusters. The issue you've got is that the money flow at the moment going from Ministry of Finance to health holding company and then on to clusters, that's going to change. We are going to have a national insurance program implemented. And Sultan, I wonder what thinking has been done around the fact that that will inevitably change the way in which the PPP contracts are working, because the money is coming from a different source. Is that something that you've thought about? Sultan, I think you're on mute.
Okay, can you hear me now? Well, there's a great question that needs to be answered with caution and selection of the word. As we stated, we have a ministry who, at the start of the transformation, was wearing multiple hats. It was the regulator, it was the payer, it was the operator, amongst other roles. And there is a clear end state where the Ministry of Health will be confined to a very specific role. The operation will be managed by a specific entities, as well as the other functions of the finance, etc. So we have an end state that is great, designed on very impressive PowerPoint presentations and slides, etc. And to go to that end state, it is not just a matter of just signing approvals and making a decision and flipping a switch. It's a very lengthy, heavily resource mandating, as well as requires a lot of capacities to be put in both the system as well in the people running the system. And this is a journey. It is not going to take to happen over a short period of time. At the same time, to enable that journey of building the capacity, etc., there has to be a parallel systems that utilizes the great experiences globally in terms of the private sector, the experience houses throughout the globe, to either, I'll not say either, to enable the government to learn from these experiences and bake them within the system, as well as relieve the operational pain from the Ministry of Health operation side and allocate it to a private sector where we can manage or we can control in terms of the payment, linking them to the quality, etc. So at the end of this, at the end of stage, we have a payer which is currently a Ministry of Finance, for example. At a certain step, the payer could be, or the signatory authority will be Ministry of Health, X, Y, Z entities. At the end stage, regardless of we are talking about Ministry of Finance, Ministry of Health, X, Y, or Z entities, ultimately, the important thing when we talk about financing, we're talking about a government which is well reputed in terms of the financial capacity, the commitment to payment, the stability of the system governing it, and as shown by evidence, the will intention as well as the commitment to the transformation program. In the same time, providing the agility to enable these projects to move forward and to have been signed in a proper legal framework that enables the signatory authority to be shifted to whatever entity has the solid legal presence and enablers to function. I hope I answered the question.
That is a perfect answer, Sultan. That was brilliantly put. I mean, ostensibly what we're talking about here is that you have a solid state sitting behind this program, and that while the entity that is making the payments may shift, what sits behind all of this is a solid and something that investors can have absolute confidence in. Richard, you wanted to come in, and then I think Barry wanted to come back as well. Richard, to you first.
Okay, thank you. Yeah, and it was just to really build on some of Barry's points, I guess, from a more technical lens. And there was just 5 quick points I was hoping to make. So the point number 1, I guess, is when we're thinking about PPP models, I think it's important to think about PPP in the widest sense. Again, often, as soon as people say healthcare PPP, people are immediately thinking about big acute hospitals and that traditional PPP model that we've seen all around the world. And I think there's an opportunity to think about where the private sector can add value, work alongside the public sector. That might be delivering acute hospitals, but there's different models that can be used. So it's about how you leverage the experience, expertise, capability of the private sector to sit alongside the public and come up with the right answers. So that was point 1. Point 2, 3 and 4 are really more about when you do embark on the more traditional PPP model. So I think, as Barry said, the flexibility is always a key challenge. And, one of the things that's important to get clear is the technical scope of any PPPs. So what are the responsibilities of the private sector in those models? And we've seen in the UK and every other jurisdiction, that changes over time. So clinical services, are they in or out? In the UK, they've primarily always been excluded, since that is the expertise of the NHS. But then, obviously building, the design and construction of the building and the hard FM maintenance of it absolutely needs to be included in the PPP. But there's then flexibility around about some of the soft services, particularly when they then, are very closely linked to the clinical delivery, and also how you deal with equipment. Again, there's been different approaches with different levels of success in terms of how you build equipment into a long-term PPP. And again, the challenge there is the technology changing so quickly in relation to equipment and how that sits in a 30-year contract. So I think getting scope around about technical aspects of the project is important, so that the private sector investors can understand, what the ask is and try and be consistent in terms of that ask across the whole program. I guess the third point then is how you, and again, thinking about large construction PPPs, is how you get an element of standardization. So what the private sector like to see, because bidding PPP projects is expensive for the private sector. And while they will show a lot of appetite to get involved early, when there's clearly a program like there is here, they can quickly get turned off if there isn't efficient standardized processes in terms of the procurement, numbers of bidders, length of procurement, the ask during the procurement stage. There's a huge opportunity here to develop standard documentation, both in terms of procurement documentation and contract documentation. And I think to really leverage the private sector and get them properly engaged, over a long period of time, they need to see that these projects are going to be, procured and run in a consistent and standardized manner. So I think it's great that there's a PPP body set up. That is the absolute perfect place for the Saudi, government to be. And it's such a great opportunity, to really get in place those things that we've seen in other countries not being done well and leading to bad projects. And I guess the last point is that making sure that each project that's done, we understand, what was good, what was bad, and making sure those lessons are transferred. And again, the central PPP unit in Saudi Arabia can really help with that. But again, we've often seen projects go wrong, but the lessons haven't been picked up. And there's so many lessons around the world. Saudi Arabia can really jump ahead here and make sure they take advantage of lessons out with, but actually making sure that each project they do in country, we are learning each time so that the PPP process gets slicker and better and delivers better outcomes each time. So I just think there are things that need to be thought about, that we know if investors see those things in place, they're very, very keen to get engaged. When they don't see them in place, they might be keen at the start, but they can quickly turn their interests elsewhere. But there's a great opportunity for Saudi Arabia to get that right and get that done better than any other country by learning on those skills and lessons learned from out with Saudi Arabia.
It's an interesting one, this, Richard, because I'm going to do a flagrant plug for the Vision Health 2022 conference that Healthcare World will be organising with the Eastern Cluster in December here, which we'll be announcing next week. So keep an eye out for this. But one of the things that we're going to be doing as part of that conference, and I hope to have you and Barry and Mansour and Sultan involved in this conversation, is we're going to have, as part of the conference, we've got a whole workshop planned around looking at lessons in PPP from around the world, not just from yourself and Barry with UK and your international experience, but also with some of the examples from the Turkish economy, because I think it's really important. And certainly what I've seen from the conversations I've had in Saudi so far, the Saudis are very, very keen. Sultan, hopefully you'll underline this for me in a moment, very, very keen to understand what went right and what went wrong in other PPP programs around the world, implement those pieces of thinking into what they're trying to achieve. So one question I'm really interested in the answer to before I move on to Barry, Richard asked the question around scope. So in terms of, as we talked about in the UK, where we have a National Health Service, which is responsible for clinical delivery was always out of scope in UK PPP programs, but there's also hard FM, soft FM, and of course medical equipment. What's the thinking in Saudi at the moment? What do you think is in and out in terms of those elements in terms of Saudi PPP?
Great question. And to answer that, still as also in line with Mr. Richard said, that we have to learn from the lessons globally. As you are familiar, there are two schools of thought on why should we engage the clinical operation, and we have it as a complete set solution to be provided by the private partner with its own pros and cons. And the other side, we have the point of view which is strictly forbidding the private sector from engaging within the clinical operation, as it is mandated by whatever ecosystem it is controlled and what is the rationale behind it. We cannot say that this is right or this is wrong, and we have to commit to a certain line of thinking, preventing the system from the positives of the other side. So we are working in parallel, enabling multiple opportunities, having multiple studies and multiple case studies to make sure that every single project yields the best possible outcome, and we are keen to have that. And strongly believing that we are in an early stage to decide what is the pathway to move forward, because regardless of the maturity of the global experiences, in addition to learning and standing on the shoulders of giants, it is very important to also pay attention to the local context of it and the unique environment that we are stating in that. For that, we have to still work more on about understanding it, observing the local and international markets, and seeing it and providing opportunities that will yield the best possible outcomes. And we have projects going that have some sort of a clinical operation engaged of it, and some of them where is just the infrastructure and the non-clinical operation.
So I think the answer is that it's still, as a number of things are, it's still to be decided, but there's probably going to be a mix of different models and different scopes from what
Yes.
you say. Barry, you wanted to come in a few minutes ago. Hopefully we haven't moved the conversation on too far and your point is still relevant. But you are muted, on the other hand.
For a moment, Steve, I thought you were in such control that you would decide whether I was muted or not. So
I don't have that power, I'm afraid.
No, actually, the issue is not that my point is being covered, but that, of course, what has just been said then makes me think about loads of other points. My first and the point I was going to make, and it was tied in really with the point which Sultan helpfully made in relation to the flow of funds and the change in effectively the funder. But it then does struck me in terms of how those funds are allocated and how the budgets work. Mansour in particular early on was talking about effectively step down facilities, social care, and so forth. And if you talk to almost anybody in any healthcare system, they talk about the importance of that. And in the UK, certainly big time, the issue of the unfortunate term of bed blocking, but that issue. And one thing I have seen in the NHS is going against all the common sense has been in which the issue about how budgets are actually allocated and basically how the various providers are paid. And so if you create a situation where a hospital receives funds by reference to the number of patients it has in its beds, then how do you incentivize the decision to move on to effectively step down care? And the next question is, if you are going to finance that step down care privately, how do you assure the step down owner and the step down financier that project will that basically there will be a flow of funds and you don't have what's the word? Counter incentives is the wrong word.
I think it's the law of unintended consequences.
Unintended consequences. So I think I think that's really important. I think the other point, all the points which Richard made, absolutely, the need for flexibility but certainty, a structured approach. If you did have a PPP for another 20,000 beds, 30,000 beds, obviously the needs will be different, but the idea of the bidders will be really put off if there's too much variation in the way that risks are allocated, definitely. And I do think the other point I would make in slightly more long term, but it comes back to my point about variations once the hospital is built. And that is you have to maintain the interests of the private sector through your original, I'll call it the building program. Bad, not the right word, but you have to maintain the interest of the private sector through the building program. And as Richard said, if it gets too complicated and starts to get too uncertain or expensive, then bidders will be turned off. Of course, once they're locked in, once you've built it, one of the issues I had on a major variation, a physical variation to a hospital, was that by the time the variation came, everyone had moved on. put very simply, I ended up having to negotiate major changes to a contract with some bankers based in Amsterdam who had not been involved in the project at all. So those planning for the future, in so far as you can, because there's so many other things to do, is a really important aspect. But I think that flow of funds and the way the budgets work is important in the shorter term.
Yeah, Barry, can I ask you a question on that? I mean, from your point of view, having written PPP contracts in the UK, having seen different models of PPP around the world, Sultan, I thought, gave a brilliant answer when talking about how the change would be managed from Ministry of Finance, Health Holding Company, into what will initially be a national insurance programme and then ultimately be a commercial insurance programme. From a kind of contractual and risk point of view, and also, I guess, from the point of view of an investor, how easy, I absolutely take Sultan's point. The Saudi Arabian state sits behind this, and the Saudi Arabian state is not a risk to an investor. Yeah? That provides some surety, it provides some certainty, and should mean that investors will be interested. But how are you going to manage that change? Because ultimately, if you think about an insurer, think about a commercial insurer, their incentives, their desires are going to be different from the Ministry of Finance. So how does that change the way in which the PPP contract works and the way in which the PPP contract is paid?
A lot, and also depends on what the private sector provider or providers are being paid for. So if you come back to the point that was raised a little earlier, what's in the PPP project? And to keep it simple, are clinical services, and then it gets more complicated because what do you mean by clinical and near clinical, but are clinical services in the mix, or are they the responsibility of the state? Or second complication, they might not be in the PPP project, but they might be subcontracted separately to a private sector organization. So what are you paying for? So from a finance, so you've got three stages. You've got the build stage, relatively short term. So let's just say you have to worry about the next 5 years. Pick that quite arbitrarily. You can kind of see what's going to happen, and you know what is going to be required, because once you fix on the building, that's what the building's got to be, and it's got to be, that has got to be built, and it's got to be built by December 2026, whatever. Just made the date up.
And that's the easy bit.
That's the easy bit.
Because
that's the easy bit.
The operational phase is complicated.
So then think in terms of the operator, the FM and that sort of thing. Probably, so long as it's quite clear what it is that's wanted, then where the funds are coming from may not matter all that much. When you come to saying, but we're going to want changes over the next 15 years because of surge, because of changes in clinical practice, and you don't know who you're dealing with yet, and you don't know who's going to be responsible for budgets, and you haven't got a clear history of how budgets are determined, that's a bit of a worry. And so if assume me to be the, just picking up on my example earlier, the slightly awkward banker in Amsterdam, and you want to build into your contract a load of flexibility. And I'm thinking, all I want to be sure is that I am getting my $XD million a month repayment of my loan. Now you're telling me who's going to be paying that? The source of that revenue is going to change, and the basis upon which they are going to make their decisions is going to be changed. In fact, there is no history of how they make their decisions. Those are the sorts of things that you're going to have to build in to reassure the financier, it seems to me. Because the inherent, I think it seems to me that the inherent advantage of PPP, one of the inherent advantages of PPP, there's quite a few of them, including new ideas and so on, so forth. But one of the advantages is you clearly set out all the risks and who is responsible for which risks. And that makes you think right from the beginning how it's all going to work and how it interfaces. And one of the reasons you often see people seeing great problems with PPP contracts is because of that clear allocation of risks. There is transparency when things go wrong, which is not the case in the public sector. And I think but I do think that there will be difficulties. Sorry, that's the wrong word. There are certainly going to be challenges in marrying the desire for change with the desire for fixed revenues, certainty of revenues, and changing players. And I'm sure people have started to think about this, but I think that's an issue which is going to have to be addressed in terms of when you're talking to the bankers, that's what you have to talk about.
I think Sultan put this really, really well quite early in the conversation, isn't it? It's kind of it's the analogy of operating on the patient while the patient is still running around the sports stadium. Because everything is in flux and is moving. It's a great analogy, that, Sultan. I appreciated that one. Mansour, I want to come to you because it strikes me that you are the experienced member of the group in terms of the contacts and work that you do with Middle Eastern investors. What's their appetite? Are they concerned about the way in which these payer models will move, or is there a strong appetite based on the track record of Saudi Arabia as a safe place to invest?
No, so I think there's a couple of points I want to add what Barry also said. So I think Saudi is at this moment is the market where everybody is looking. We are basically we are dealing with investors from all over, from Saudi mainly, from GCC, from Europe, and other places also looking at the Saudi market. I think the key thing which they are there is more, and the way the thing has changed in last few years or so, there is more, and the laws and ownership laws and everything has changed. There is more and more sort of confidence level has increased. As I think I can say that confidence level has increased. Plus also there are a number of projects which are at different stage. Mr. Sultan knows better than us. At different stages. I think one thing is that once couple of projects will be up and running, the confidence level will just jump from 1 to 10, because people can see that was not just on the paper or discussion and other. These are the projects which are basically open and successfully running. So I think that's the thing is we are getting all sort of investors. We have investors who want to just invest in the real estate, build up buildings and other, and basically lease it out. We have investors who are looking to invest in the operating business also, and we are the operators who are coming from all over the place. And I won't take the name, but a couple of international operators, they are opening their branches after opening in Dubai, in Jeddah and Riyadh. So the appetite is there, the confidence level is there. I think we need to see some success stories which are up and running. I think I wanted to add two more points that Barry has mentioned, just to take it from there. One is that, Barry was mentioning about the fixed revenue or payment versus the variable, another, and what are the guarantees there, I believe. So I think one important thing is that there is, we need to do more. I would say it's done, but I think we need to do more, where when we are doing the projection, patient numbers and other, which ultimately, reflect into the revenue and operating expenses and budgeting and everything, we need to be more careful and realistic. We should not be doing, follow one rule for everything. Like, we do a lot of feasibilities and other for private sector also. And when you talk to a private investor, the first thing you will say, operating break even in year 3 or 4, payback period, 7, IRR is whatever, 15%. They have a mindset irrespective of whether it's a specialized hospital or general hospital or something like that. So the projections and other which reflect on the everything, basically the cost of the hospital, the repayment, the budgeting, the profitability and everything, the patient number and the flow of patient and the mix of those patients should be very, very realistic. They should not be just considered that it's sorry to say, I'm ex Big Four and Collier. That's not an accounting exercise. It is something which it need to be realistic, because if your model is not built properly, everything can go wrong once the hospital is operating. The other thing is, and I think Richard can add more to it, when we talk about the size of the hospitals. Now, privates, when we do feasibility or working with government sector or the private sector and looking at a brownfield or greenfield hospital, another. It's like, if it is a public sector hospital, and Mr. Sultan, correct me if I'm wrong, it is like 250 meter per gross area per room, or 300 meter. The private sector could be, irrespective of whether it is a long-term care, it's a rehab, it's a maternity, another. Normally, we have seen in 80% of the cases, one rule apply for all. They basically, this is the hospital. If it is in private sector, between 100 to 150, public sector 200 and plus. We need to see what will be the use of it. And, that will change construction cost. Just if you look at the construction cost, they can be like $300 to $400. $1,000, per meter. So we need to make sure that we are basically equipment cost another. So I think that's another thing, is that when the design is coming, it's again need to be build what would be the end purpose of this hospital, what would be the mix and specialities which will be offering there. And that's why I think what Barry has said, I 100% agree, that in most of these cases, we should know who is the operator, and the design and operating plan should be we should make that hand in hand with the operator, not that somebody else is doing it, and when the operator comes, there is a 30% variation in that. So I think these are the couple of points, is that rule should not be applied on all the hospital which we are making. We should from the beginning know that, and the last thing is actually the way the disease pattern and I know it doesn't change in to 1 year or 2 year or 5 years, but the way the things are changing, that the number of diabetes, the old patients, and 60 plus year of population in Saudi, and other lifestyle diseases and other, there should be a flexibility. A hospital is not which you can demolish it in 5-10 years and rebuild. There should be a flexibility that in after 10-15 years, there could be some change could be done, which is not cost you a lot. So these are what the things which we have seen, it that people, investors, especially the investor, they're too much concerned about how the hospital look, not how operationally it will work. They want to make it a beautiful building, and there is less emphasis on the operational side. And I think that's why it is important to engage somebody who knows. I mean, a designer, hospital designer, is not who is designing a hotel. Hospital is far more different than, so you need to engage with the right advisors. That may cost you a little bit more in the beginning, but that will save you millions every year.
Thanks, Mansoor. Sultan, you wanted to respond to that? Sultan, you're on mute. You're muted, Sultan.
We still believe in your power to unmute all of us. You are rightfully, Mansoor, when you talked about the issues going with the design, and people, not even public but even private, when they design it, they sometimes think more toward the hospitality and hotel design rather than clinical operation. And for that, and what we found, and we are working on it, is that it is the best way to approach it is to do two things. First of all, you have to bring the best international players to partner with, and the other thing is that the link of the payment is to the outcome, whether it's about a volume or it's about a quality of it. For that, you are giving the freedom to design the operation purely to those who are experts in it and who have been in it far too long, and you want to learn the lessons from them. And you will gain two things. First of all, you will increase the operation, whether quality or quantity or even a cost reduction of it. And the other thing is that you will provide a live demonstration and lessons learned for all of the system. I'll not say copied, but you will provide a business case that can be studied locally and fit to and altered and modified to fit the other cases in Saudi Arabia. So I hope that this answers it.
No, they're very useful. Richard, I want to come to you on this point, because obviously, as Mott MacDonald, you get involved in the kind of design and pre-construction phases of these kind of projects. How do you respond to this idea that that too many of these hospitals are designed for form rather than use?
Yeah, see it all the time, and absolutely, that is one of the opportunities through some of the comments I made earlier about standardizing approach, particularly from a technical perspective. You know, one of the things we are involved currently in the UK around is, and the UK are really pushing the boundaries with how they're approaching the new 40 hospital programme in the UK, and very much pushing a number of things. One of those things is standardised designs. So if you think about 40 hospitals, they all have the same rooms in them. So why design the same room 40 different times when you can design it once and build it 40 times? So again, I'm not sure how that could be achieved, you know, given the cluster approach, but it could be achieved in a PPP environment. You know, there's an opportunity for the design, some components of the design to be done up front, which are then pulled down and included in every hospital that Saudi designs. And other things that are really important is making sure the hospitals are digitally enabled. So what does that mean? And, you know, for a hospital to be digitally enabled, it's not about building the hospital in isolation and then thinking about which digital technologies you install at the end. It's very much back to Mansour's point about, you know, you need to do the design to respond to how it's going to be operated. And in deciding how you're going to operate it, you need to think about what digital technologies are going to facilitate that operation. That needs to be the bit you do up front, and then you design the building to suit. We see cases in some countries around the world where the building gets designed and built, and then they find an operator, and then they think about digital. That's all the wrong way around and won't deliver any sort of value, or the right hospital to deliver the right clinical services. So, you know, the Saudi Arabia has got the opportunity to control that from the start. Again, there's a PPP unit set up. So, as I said earlier, you know, real opportunity to make sure that Saudi Arabia learns from all the things that have gone wrong in different countries, and this being one of them. So, you know, it needs to be about the functionality of the building to help deliver the clinical services, not how beautiful the building looks from the outside.
It's an interesting one, actually. Barry, I remember you and I having a conversation some years ago now about some of those early PPP contracts that you were involved in the UK, and the fact that when those contracts were written, the internet was hardly a thing. And as a result, you know, how do you retrofit something as big as digital health into a contract midway through? Now, obviously, Richard there is talking about, you know, building digital health at the start, but who's to say there isn't some other big innovation that needs bringing into these contracts midway through? How would you, you know, if you know, looking back at your experience, how would you have kind of future-proofed those contracts that you wrote back in the day in such a way that the internet would not have been a major problem in terms of its implementation?
I think that's extraordinarily hard. I think it's this balance between effectively, so Tom's talking about contracting for outcomes effectively. And before that, you've got contracting for outputs, you know, along the scale, and then there's the contracting for inputs. And it's how do you balance those different approaches? Because if one looks purely at the outcome, I think there is a difficulty in to use the phrase comparing apples with pears, being uncertain as to what is required and then from the other side what's on offer. I mean, the sorts of examples that I can think of was when I was negotiating my first contract, I think we got bogged down in discussions about the cleaning contract. Took a disproportionate amount of time. But everyone was sort of joking about all the robot hoovers and cleaners that one could use. And we thought that was a bit of a joke. And of course, it isn't anymore. And then another case, we had a situation where the hospital was built, and then later on, people realized that, actually this was much later on, but we did this contract, that the hospital was built, and then people started to fit in all the wireless technology and realized they needed to knock holes in walls and things because it had not been planned for properly. Another example was we really worked really hard on the medical equipment services contract, which was included in this particular contract, and looked through what happened if, and how do you deal with variations every 5 years and changes in requirements, who paid for what, and then ended up later on in an argument about who paid for the increased bandwidth, because no one had really contemplated a situation where when you bought the new medical equipment, it would all be wireless. It would rely on wireless technology, and therefore you substantially need to increase the bandwidth within the hospital. I think the only way you can do this is come back to design, as much flexibility in the design of the hospital to make changes as cheap as possible when they come along. And coming back also to the contract management aspect, both what's written down in the contract as to contract management and the way in which contract management is resourced by all the actors involved in the operation of the hospital and indeed the wider healthcare system, is to build in opportunities to assess, discuss, forecast as you go along. And that isn't a sort of strict way of dealing with things, but if you have regular interface and regular discussion, if you try to create as far as possible, and I wouldn't want to sort of glamorize this too much, but if you try and emphasize the partnership bit in PPP in terms of how the hospital is actually operated and how all the relevant stakeholders, I hate that word, but all the relevant stakeholders involved are involved in the process. So the contract, this aspect of the contract is essentially the contract providing for the way the contract will be managed, not trying to predict the outcomes, but to make sure there is regular discussion and that change on the horizon is looked at and thought about, and not suddenly everyone having to deal with it when you actually reach the horizon, if you can ever reach a horizon. I think that's important. So I think the contract management aspect is something that needs to be looked at very carefully, and having everyone involved, properly resourced.
I think it's interesting. The one thing that we've touched on, I think, a few times over the course of this conversation is the opportunity that Saudi has. We've got an opportunity to do things differently. We've got an opportunity to learn the lessons from various PPP programs around the world. And I think it's really important. We've only got a couple of minutes left, so I'm just kind of summing up the thinking here. But I think it's really, really important to understand that, in the UK, there's been a certain amount of political and media PPP bashing. And again, Barry, you and I have talked about this numerous times in the past. The fact of the matter is that, what we've done is delivered an enormous hospital program at scale and at speed. And done so in a way that has provided clinical care to millions of people. So there are huge benefits in PPP programs, and a huge opportunity in Saudi to get this right. And I think that to me is the excitement of the whole program. Really, is there is an opportunity to be innovative, to do new, clever, smart, interesting things, and that's what I really, really love about this whole program. Sultan, final word to you. How, there's lots of good thinking around the world. There's lots of people that can help, whether they be operators, contractors, consultants, investors. What's the best way for the international community to engage with the PPP program in Saudi Arabia?
This is a great question. And first of all, such events and such symposiums are a great way to do it. Also, in the National Center for Privatization, one of the pillars of its existence and functions is to promote the investors bi-directionally, to get the investors with the NCP as well as NCP to reach out to them. So the Department of Investors Relations and also which can be accessed through the website of the NCP is a great formal gateway to engage with the PPP programs and the privatization programs in Saudi Arabia. And this is not limiting the private investors and the international experiences to also open, communicate, and exchange with all of the relevant parties within the health sector in Saudi Arabia, knowing that we have to differentiate between what is the point that is structured and established, and what is the self-inferential or self-understanding of the change happening.
Thanks very much for that, Sultan. And that's all we have time for, I'm afraid. Fantastic debate, really, really interesting. Thank you so much to my panel, to Barry Francis, to Mansour Ahmed from Colliers, Richard Cantley from Mott MacDonald, and of course, some brilliant insight from Saudi Arabia, from Sultan Al-Amma of the Centre for Privatisation and NCP. If you missed any of the session, it will be online. You'll be able to watch it back probably in the next hour or so. Keep an eye out for more sessions coming up on the Healthcare World Series, and a big announcement coming next week about the Vision Health 2022 conference that we'll be doing with the Eastern Cluster. Thank you so much.